Hello, this is Dr. Emmanuel. Welcome to my channel. I want us to look at how we can approach a PLAB2 station on the topic back sprain. Okay, so a patient who is going to come to our clinic, and we're going to have 8 minutes to assess them. And the presenting complaint is back pain. Okay, back pain. We're going to see that this patient is going to have normal examination findings. Okay, no red flags, and we're going to make a diagnosis of back sprain. We're going to manage this patient. So this is a typical PLAB2 station. A lot of doctors who are going in for the PLAB2 already have so much knowledge about back pain and its management. But the reason why I've decided to do this video is not to teach you what you very likely know. You might even know much more than I do as regards the management of patients with back pain. But I'm here to guide people who haven't had a feel of what working in the UK is like, who haven't had, a feel of what the NHS structure is like. So the PLAB2 exam is actually designed, to assess you using the UK standard and UK structure, okay, the structure of the NHS. So having a knowledge of how the NHS operates is just going to make your PLAB2 examination much easier. So let's move ahead. So in this station, you are the foundation year 2 doctor in emergency department. Mark, a 40-year-old man, has come to the emergency department after developing back pain while exercising at the gym. He's concerned that he may have developed a slipped disc. Assess him and discuss management with him. So you are the FY2, which means you are in the second year of your internship in the UK, and you are doing maybe your 4 months or 6 months, usually 4 months, A&E posting, and a 40-year-old patient, 40-year-old chap, by name Mark, has come to see you with complaints of back pain. So what are the domains or competencies that are being assessed in the PLAB2 examination? First of all, they're assessing your interpersonal skills, and by that, they're assessing your consultation and your communication skills, how well you communicate with patients, how well you understand patients, how well you empathize with patients, how well you check that patients are understanding what you're saying, how well you check that you're exploring patients' ideas, what patients think about their illness, what are they most worried about, their concerns, and what do they hope to get from that consultation, which are their expectations. They assess your data gathering skills and interpretation, how well you're able to take a good history, focused examination, request relevant investigations if necessary. And then you're assessing your management and decision-making skills. Okay, and that also includes safety nets and follow-up. So, how you're able to give patients safety nets and how you're able to arrange follow-up or referrals. So approach. First thing, while you're waiting for the bell to go, for you to walk into the room, you read the question outside that particular room for that particular station, and you've already read that. And then the questions you need to ask yourself is, first of all, where am I? You're in the emergency medicine, in your emergency department. You're not in the GP surgery. You're not in orthopedic clinic, okay? You're not in orthopedic clinic. You're not in the GP surgery. You're in A&E. So that's going to influence your management, because in A&E, you have easy access to X-rays. You have easy access to CT scans or MRI if you need that. You have easy access to doing blood tests, like full blood count, any blood test you want to do. But if you're in the GP surgery, even if you take blood tests, the results will not come back the same day. If you request X-ray in the GP surgery, patient might not get that X-ray within the next 2 weeks. Okay, so in A&E, you have more access. So you need to ask yourself, where am I in A&E? Who am I going to see? You're going to see a 40-year-old chap, gentleman, whose name is Mark. And then why has Mark come? He's developed back pain. What are his concerns? You need to ask yourself, what is Mark going to be concerned about? And it's already given to you in the question. He's concerned that he might have slipped a disc. You have to explore his ideas about slip disc. What are his expectations? Why has he come? Very likely Mark has come to have an imaging. He might tell you, oh, doctor, don't you think I need an X-ray? Or don't you think I need an MRI scan? Explore his expectations. Of course, you would need to take a history, how did he sustain this injury, or, trauma, whatever. You would, of course, an incident history, how it happened. Are there symptoms and signs of cord compression or caudal equina compression? So in the UK, once a patient is having back pain, they want to see you rolling out red flags. And usually those red flags are, signs and symptoms of cord compression or caudal equina compression, and also infection. So discitis or osteomyelitis of the spine, of the vertebral bones needs to be ruled out. Okay. Ask yourself any other differentials like discitis, TB spine. Tuberculosis is not common in the UK. So it's not it's not top of your differentials. Of course, spinal tumors, a patient with spinal tumor can have back pain, okay? But usually it wouldn't be an acute back pain. You want to find out if he's tried anything. If he's tried any painkillers, if he's tried, warm compresses, if he's tried ice packs, if he's tried paracetamol tablets or paracetamol ibuprofen gel or ibuprofen tablet. You want to know what he's done, okay? And when we look at ruling out red flags, you want to ask him things like, has he noticed any weakness in his arms or legs? Has he noticed pins and needles? So paresthesia is described as pins and needles. Has he noticed numbness in his legs, numbness in his saddle area? So saddle area, the word saddle is a commonly used word because people cycle a lot in the UK, okay? And the seat on which they cycle, the seat of the bicycle is called a saddle. So you ask them, do you feel any numbness or pins and needles in your saddle area? Any difficulty passing water? So water is a common or layman's term for urine. So do you feel any difficulties passing water? Have you noticed that you're leaking your water? Any troubles, any troubles controlling your bowels? When last did you open your bowels? When last did you pass urine or pass water? You want to explore that. And worsening back pain, severity of the pain, okay? You need to ask those kind of things. And still on rolling out, red flags. When it comes to discitis, you want to ask if he's been running temperatures, if he's been feeling hot and cold. So hot and cold means feeling feverish, with chills and rigor. Has been feeling hot and cold. Has he got, any other symptoms? Of course, you ask all those questions. Then because the question says, if we go back to our question, let's go back to our question. The question says, assess him. So if you look at that question, it says, assess him. So in PLAB 2, when they use the word assess, they tell you take a history and discuss management. It means take a history and then discuss your treatment. If they use the word assess, they mean you should take a history, focused examination, and then you discuss your management. So in this situation, Mark has come to you. He was in the gym. He developed sudden onset back pain. He has no red flags. He has no leg weakness. He has no pins and needles. He has no numbness in his legs or his saddle area. He has no difficulty passing urine. He has no troubles with his bowels. So he's got pain. And next thing you have to do is you have to examine him. So examination has to be a focused examination. First of all, you might want to do his, vital signs, check his temperature, make sure he's not having fever. Because if he's having fever, you might start thinking towards, possible discitis or osteomyelitis of the spine. So check his temperature, do a general examination, do a focused examination, tell him to expose his back, look at his spine. Have you noticed any redness? Have you noticed any, deformities? While he stood or while he's lying, you can tell him to lie, lie semi-recumbent. You run your hand, you tell him you're going to run your hand from the top of his spine and the neck down to his sacral part of the spine. And if he feels tender, he should let you know. So you run your hand gently across the whole length of his spine, looking out for tenderness. And then after doing that, you also feel paraspinal soft tissues just on both sides of the spine. Okay, you can use your thumb and your index finger, run it down, ask him if he's tender. He might tell you, ouch, feels pain somewhere. Examine his lower limbs, do the straight leg raise, check if he's able to elevate his right and left legs, with a straight leg, see how far he can go. Assess for the power, the the power, the thighs, the legs, the ankle, check his deep tendon reflexes, check his sensation, touch sensation using you can use your cotton wool, and then you can check for pinprick using the sharp tip of your tendon hammer. Okay, you can use that. Assess is so usually in this kind of situation, neurological examination will be completely normal. So after doing the neurological examination, you have to, at the end of it, you have to do the anal. You have to tell him that when patients, when people, sustain back injuries, we usually want to assess their back passage to check the strength of the toe, the strength of the muscles of the back passage. Also check for sensation. And then, this entails me putting one of my fingers in your bum and asking you to squeeze on my finger. Would that be all right? Tell him that I understand this might feel very uncomfortable. Offer him a chaperone. Would you want someone to be here while we carry out this examination? A chaperone. Offer a chaperone because it's an intimate or private examination. So check the anal tone. Insert your finger. Ask him to squeeze. If he's able to squeeze, that's fine. You can use the sharp tip of your tendon hammer, or you can use a needle, a blunt needle. You can use a blunt needle to feel for sensation. Examination will be normal in the case of back sprain. Of course, if the examination is abnormal, and you would have to, you're in A&E, you have to discuss, tell him that if the examination is abnormal, maybe he has leg, reduced power, or reduced reflexes, reduced reflexes or breath reflexes, depending on what's going on, or he has altered sensation, then you tell him that I'm a bit worried from my examination findings. I would like to discuss with my registrar consultant because I think you might need an MRI scan of your back. Okay, but in this situation of back sprain, examination will be completely normal. So what you will tell him is that, Mark, I've examined you and I've taken a history from what you've told me and from my examination findings, which are examination is completely normal. I think you're having what we call a back sprain. I haven't identified any red flags. I'm not particularly worried that you might be having what we call caudal equina syndrome, which is compression on your nerves. Compression on the nerves in your spinal canal. I'm not very worried about that. I think you have a back sprain, a simple back sprain. And there are a couple of things we can do to help. I advise you take some regular painkillers like paracetamol, ibuprofen, to help control this pain. You could try things like, applying a heat pad on your back, or ice packs, and they encourage him not to keep stiff. He should keep moving as much as the pain will let him, just to avoid stiffness. And then, still part of your history, I forgot that you should have also asked him if he's experiencing back spasms, because if he's having back spasms, you might need to give him some PRN, oral diazepam, with 2 milligram diazepam 3 times a day for maybe 48 hours to help relieve the back spasms. And then, of course, you need to do a safety net. So safety net is very important. You have to tell him that if he goes home and he develops worsening back pain, leg weakness, pins and needles or numbness in his legs or in his saddle area, if he notices difficulty passing water, he starts leaking his water, or he's unable to control his bowels, then, of course, he needs to act immediately. And how can he do that? He can call NHS 111. Sometimes the waiting time, you could call NHS 111 and wait for close to an hour before someone answers your call. So if you tell him your call, you can try NHS 111. If nobody answers your call within the next 15 minutes, call 999, which is the ambulance service, or you can just tell him to call 999 immediately if he notices any of these. Or if someone is able to bring him straight to the A&E, maybe a relative, they could bring him straight to the A&E, and we will need to be re-examined because he might need an MRI spine of his back, okay? To make sure he's not having cord compression or what we call caudal equina, which is compression of his neck. So you must give that safety net. You must tell him the red flags to look out for and what to do if he notices or if he develops any of those red flags. Then you can also tell him that if this pain doesn't go away in the next 1 to 2 weeks, he can book an appointment with his GP. GP might call him in, re-examine him, or give him stronger painkillers if paracetamol and ibuprofen haven't worked. And of course, if the GP is worried, the GP might need to refer him back to A&E. So you must do that. So we've come to the end. So essentially when you're told to examine or assess a patient in A&E who has come with back pain in your PLAB 2 examination, they want to see you ruling out red flags. And those red flags are discitis, caudal equina, or cord compression, okay, osteomyelitis. So you must rule out those. You must ask for fever. You have to also ask for weight loss, because weight loss might tell you this patient is having a spinal tumor or even tuberculosis, which is not common. But if they tell you a situation with a patient who recently came from Nigeria, or a patient who recently came from India, when they use those terms in PLAB, they're talking about tuberculosis, or malaria. So if they tell you a patient recently came from Pakistan, developed back pain, and he has weight loss in your history, you think of tuberculosis of the spine, Pod's disease, okay? Weight loss, of course, you start thinking of, spinal tumor and all of that. So you ask more questions towards, like loss of appetite, weight loss, night sweats, pain waking you up. If the pain wakes you up at night, that's another red flag for tumor. So if back pain wakes you up at night, might suggest that it's a malignancy, okay, like a lymphoma or whatever, or a spinal tumor. So take your history based on the kind of questions, but you must be seen to be ruling out cord compression, caudal equina compression, discitis, osteomyelitis, plus or minus, there's so many things, but you have just 8 minutes, so everything should be focused. This is fairly straight to the point. He was in the gym. He felt his brain is back. He's concerned he has a disc prolapse. So it's more of a trauma history, isn't it, than spinal tumor. So we've come to the end of this discussion on back pain as a PLAB 2 station. If you think this has been helpful, kindly like this video, subscribe to my channel, share this video with friends, and maybe family. Thanks for your audience. Bye-bye. Yeah.